Thank you so much, Helen. Really so powerful and so wonderful to have your thoughtful contributions today to help us keep in mind what the goal is. You have bookended brilliantly with Harvey Feinberg's comments and others about the central role of patients. So we have an opportunity now to open up and address some questions to Dr. Feinberg as well as our panelists to more fully explore this topic. And I've already received some questions coming in from members of the public watching this, and I guess I want to maybe throw out one to start that probably is very much on everyone's mind. We are in the midst of a new diagnosis, if you will. COVID-19, the pandemic, has challenged all of us as a society and around the world. And a questioner asks, what have we learned, or are we learning, can we learn from the COVID-19 pandemic about diagnostic excellence and maybe how that might even be applicable to what we're mainly talking about today, sepsis diagnosis. So I'm wondering if any of our speakers might want to reflect a little bit, because I'm sure many people are thinking, wow, if we could improve diagnosis, this would be a particularly important time in the world to be able to do that. So I'm wondering if any of our panelists or Dr. Feinberg would be interested to reflect a little bit on that.
Andy, I'll be happy to start off the conversation on this very important, timely question. One lesson that emerges from thinking about the COVID challenge in connection with diagnostic excellence that was kind of in the background of many of our remarks, but now could be brought more forward, is that diagnostic excellence means not only getting it right in every individual, but it also has a dimension of availability, applicability, comprehensiveness to the whole body of the population of patients who are subject to the problem. It's not enough to get the diagnosis right in some patients with sepsis. It's critical that the entire population vulnerable to sepsis have the right diagnosis, as each of the speakers has emphasized. That lesson comes home very, very starkly from COVID. The COVID disease, of course, is distinct to the problems that we're talking about as a novel condition, one for which there were not previous specific tests that were available. It has illustrated also the varieties of technical approaches toward reaching a diagnosis. For example, Michael in his comments very astutely reminded us about the evolution of understanding of disease from a 19th century pathophysiologic model to today's much more sophisticated appreciation of disease. That lesson also comes through in the diagnosis of COVID, the detection of change in the virus over time, as well as the understanding of the sequence of disease in any one patient and the value and role of different diagnostic tests to provide meaningful information at different stages of the illness. Another important lesson from COVID, and very important in light of Helen's emphasis on being able to detect transitions in the state of illness that could signal the beginning stages of sepsis in our case today, or any change otherwise. So these are some of the broad lessons, I would say, that apply from the COVID experience. There are, of course, COVID-specific issues around availability of testing, technologies for testing, interpretation of testing, regulation and approvals of testing, and deployment strategically of testing, as well as the policy framework for it. But those take us, I think, rather farther afield from our discussion today.
So, Andy, I could jump in and add a couple of insights from the sort of the big population perspective. It's really interesting that we've come full circle. Our construct of help-seeking behavior that William Osler gave us, the diagnostic construct, came in the background of infectious diseases. The two world's most common killers were tuberculosis and pneumonia at the time that William Osler was doing his thing. Then we saw a real waning of infectious diseases, and we turned our attention to chronic illnesses, where a patient could come in with no help-seeking behavior, and we noticed their blood pressure is 170 over 100. Now we're telling them they've got a problem that they didn't have. So the construct has really changed. Now we're back to dealing with a pandemic. In the health systems, trying to understand it, there's all these issues of timing, and we've got people that are waiting around an emergency room because they can't go back to a nursing home because the test is going to take 17 hours to come back. And when we're talking about the progression of this disease from a health system perspective, we've struggled with how do we classify. So I can't agree more with our other two panelists that it always comes back to the importance of the patient. But to understand the biology of the disease as a population scientist, I need to know how come some people get severe disease and some people don't. Well, now we're having trouble even classifying severe disease, and I'll give you an example. One example is we use hospitalization as a marker of severity. Then we use going to the ICU as a marker of severity. Well, it turns out that some people are hospitalized for social reasons because they can't go back to the nursing home, so they're not sick. And so the hospitalization turns out not to be a good metric. Or some places are using the ICU as a COVID unit, not as a place that are where they're sick, because in a smaller hospital, they have the right laminar flow and things like that. So it really creates enormous challenges, both at the patient level, but also at the system level, in trying to understand a new disease. And it's been very humbling for those of us in research to try to wrestle with generation in a rapid succession of good science in the field.
Terrific. Thank you. I want to acknowledge a couple of audience members have sent questions that are relatively specific to sepsis and trends in the emerging epidemiology of what leads to it, and questions about management of kidney injury in that context. I think I'm going to recommend that we move some of those questions forward to our next panel, when we will delve more deeply into the specific aspects of sepsis as a diagnosis, and maybe try to continue to focus here on some of the high-level questions about diagnostic excellence. And I can't help but want to challenge, and I'm wondering, Dr. Verghese, if you might be willing to just reflect on, and we talked about this a little bit, Michael just brought up Dr. Osler, and it brings to mind for me this notion of, what medicine was at one time was purely about diagnosis, because of course the availability of treatments barely existed, and most of what physicians would spend their time doing is trying to make diagnoses, which was probably very scientifically satisfying, but not terribly helpful for many patients because we didn't have treatments. Now, of course, we have a world in which we are flooded with treatments, sometimes treatments in search of a diagnosis, if you will. And I'm wondering, in your mind, if you sort of reflect on that, has the role of making the diagnosis changed in some way? Do we sometimes now just skip ahead to the treatment phase? And I'm curious how you think about the balance between, is diagnosis the gateway to treatment, or is it still, or is it in some ways a lost part of the process? And I'd love your reflections on that.
Thank you, Andy. Before I do that, I can't help but reflect on one aspect of COVID that fascinates me. And that is we are living a plague narrative, and we have all these previous wonderful plague narratives from Camus, from the Decameron to Defoe. And I think of them as being the medical record. In essence, we have a medical record that no one has studied. Because had we studied them, and I think it's a failure, not just on our part, but at the macro level, and failure of administrators at the macro level, we would recognize that all the societal conflicts that we're now seeing, the litmus test of people being on this side or that side, the denial, the heroism, the resistance, all these things we could have better anticipated. And I'm struck by the fact that if we make the analogy to the medical record, to data systems, we had this huge database that we never quite tapped into in this epidemic, and we're still not tapping into. We're reliving the lessons of Camus because I think in some ways we're illiterate when it comes to meaningful pasts that can really inform our history. So this is just a plea for humanism, less so among medical students and physicians than amongst our, enlightened leaders. But to come to your question on diagnosis, I think that as much as residents and medical students are enthralled by the process of it, and as much as this whole conference is dedicated to it, I think we should remind ourselves that the great burden in America is one of chronic disease, where diagnosis is less the issue than it is the patient feeling that, that we are meaningfully continuing to engage with them, despite the fact that we have come to a diagnosis and the prognosis may not be particularly uplifting. So sometimes I think we get locked into this diagnostic exercise as though that is the whole essence of medicine, and especially if you sit in on morning reports, the grand tradition of morning report at any hospital, it would seem as though that is really the grand focus of medicine, very much as it was in Osler's days. And as you point out, we do have better treatment. But for the patient out there with chronic kidney disease, with congestive heart failure, there is nothing necessarily new that we're going to discover in terms of a new diagnosis. But I think it sometimes comes with a level of disengagement that is almost as deadly as not making a diagnosis. So I think I'll stop with that.
Yeah, right. Yeah. And, Helen, I'm wondering, you really, something you said in your comments that I found really powerful was this issue of creating an environment in which all members of the team are able to feel confident in using their voice on behalf of the patient. I'm wondering, through all the great work you've done, if are there particular approaches that you think will be fruitful as a way to think about how to do that, how to, so much of this conference is really about opening up the resources to maximize their potential to improve diagnosis. What do you see as the key to be able to do that? I mean, you've called it out, and I think that's so important in the beginning to be able to fix something, to identify there's a problem. But I'm wondering if you can provide any additional insights about how we might make progress toward that goal.
I think the real key will be patient input into data, into medical records, and I guess it goes without saying, better patient input into the diagnostic process as it's occurring. So one of the things that there are a number of things that we wrestle with. One is the reasons for disparities in diagnosis, and we're seeing that now in COVID a lot with these long-haul COVID patients who are being dismissed and really treated as though they couldn't possibly be ill on the basis of negative tests, even though the tests have a very high false negative rate. That's simply sort of dismissed from the equation. And people are not getting any sort of help or comfort. So I think that's one issue. We need to get past that. Whatever it is that causes practitioners, not just doctors, but all diagnosticians, to sort of treat people with disdain is something that we have to get past, because people always have important input, and obviously they don't if they feel dismissed. And the other thing is giving patients the rationale for their diagnosis. So having a proper discussion with them, saying, I think you have this because of this, allows for correction of mistakes right at the beginning. And then, patient input into data, I think, will change everything, because you will get long-term outcomes, which we don't have now. A lot of what surpasses as outcomes is really assumptions that this patient had this, and therefore that was their outcome. And it may not be the correct diagnosis. The patient may have a long journey and end up somewhere totally different. And the original physician never knows it.
Great. I want to just tee up one other potential appearing dichotomy among our panelists. I mean, we've heard from you, Michael, about the power of data capturing enormous amounts of information from millions of veterans. And on the other end, we have you, Abraham, telling us about the power of the story. I don't know if Michael's capturing stories in what he's doing, but how do we put that together? Are these parallel tracks, or what? How will all these data? Is that a challenge to our ability to listen to stories, or will it enhance our ability to listen to stories? How do you reconcile what seem to be very different ways to, in fact, gather information and to form knowledge, if you will? And I'd start with you, Michael, and whether stories are at all remain prominent when you're gathering bits of data, and how do you see to reconcile those two things?
Yeah, well, I think it's the essential question. The learning healthcare system concept. I have to tell a humbling story that I missed the diagnosis of COVID in my daughter. She finally, after about 4 or 5 days, I thought, well, maybe it's allergies. This was in March. She's sequestering over in Cambridge as a graduate. And hadn't been in contact with anybody, but it was back in March. And then she said, I've lost my taste and my smell. Well, we didn't know about that then. But then I started seeing some of these, and I said, you've got COVID. Finally, after 7 or 8 days. And then she finally got antibody tested, months later. So it is all about stories. Just like, I'll tell you just one story that I would hope. So I was buying gas at my wife's cousin's wedding in Ireland, and I swiped my credit card in the device, and it spit out a little thing that said referred. Didn't say accepted or declined. It said referred. Next thing I know, my cell phone rings, and my cell phone says it's a machine somewhere in cyberspace. The machine had detected that I was either a fraud or a customer, and it needed to know do you have your card with you? Are you trying to buy gas in such and such place in Ireland, and would you like us to keep your card activated? And I said yes, and it solved a personal problem. If I couldn't get gas, I was in trouble. But the system helped, and so it's all about individual stories. That's a personal story, and every one of these, I go from my clinic to the big data using artificial intelligence, and I think that the data that I have is only as good as the data that it comes from the interaction with the patient and how it's input. On the one hand, on the other hand, I do think that there's an awful lot that we can learn from integrating data and presenting it in better ways, so that we can do what Abraham and Helen have told us about. Is that we can get the story right.
Andy, I think. Sorry, go ahead, Helen.
No, I'll just quickly say, I think.
Oh, go ahead, Helen. Sorry.
No, I was just going to say that big data is really essential to the story. I think a lot of studies miss the patient story that's in the big data and end up therefore inaccurate. So I think there's a critical symbiosis there.
Abraham?
I was going to just add that I think it's a little bit of a false dichotomy, where I'm the story person, Michael's the data person. I think we're all on the same team. And I think as we get better at gathering data, we will actually consider, that element of distinction gone. In fact, Alvin Feinstein, the great giant of, clinical reasoning, famous textbook, people sort of falsely think of him as the evidence-based medicine guru, because evidence medicine has come to mean focus on data. But, Feinstein said, and this is a direct quote, "Clinicians can bring science to clinical judgment by better exercise of the very human capacities that appear to impair it, by giving increasing attention not to laboratory substances and inanimate technology, but to sick people and the human methods of evaluating illness." I mean, that was Feinstein's focus, not lab printouts, but really us as experienced clinicians gathering good data from the patient. And I think that, in a sense, we're all on the same team, and we just need to make that vision of Feinstein's come about for better diagnosis.
Fantastic. Great. Well, we just have a minute or two left in this session. I do want to maybe just turn one last time to you, Dr. Feinberg, and just say, are you hearing in our addressing of questions in this session themes that you think will be not only relevant for sepsis, but across the different workshops as we undertake this work in conjunction with the Gordon and Betty Moore Foundation at the National Academies? And just love your final reflections on that before we turn to the next session.
Well, Andy, thank you. I'm thrilled with the insights we've been hearing in this session. From the point that Michael started with about communication of information as being a critical part of excellence in diagnosis. It doesn't do any good if it is just separated. Abraham reminded us that the diagnostic process begins before you think you're beginning it. It's at the first interaction, the first observation, the first way of thinking about that patient. And Helen, I think, brought forward not simply the patient as our object and concern, but the patient as partner in informing, enlightening, and taking an active part with the family in producing timely and more accurate diagnoses. These are all dimensions that are quite valuable in filling out the meaning of excellence in diagnosis. And I hope that they will resonate through the rest of the sessions that we hear today and into the other panels as well. And thank you, Andy, so much, and to our staff for helping us to get launched in this wonderful way.
Well, thank you, Harvey, and thank you, Michael, Abraham, and Helen. This has been a fabulous way to kick off today's workshop. And you did fantastic work. So now let me just turn over the podium to my colleague on the planning committee, Dr. Saul Weingart.